I'm going to wait a few minutes, just because people do roll in after the top of the hour, and we want to make sure we have as many folks as possible. All right, it looks like we're starting to get to the number where I start announcements, at least, because a lot of that is the daily beat. Welcome to our March 3rd public call. We're going to continue our work on health literacy and kick off and frame some of our work on medical cost burden and health insurance status. Again, this is kind of a set that we conceptualized to think about things that influence healthcare access and healthcare utilization. It was in response to some of the Healthy People 2030 goals and to some movement in the ecosystem to build terms. We've worked on medical cost burden in part in our work on material hardship. We wanted to elevate it again. And then we wanted to respond as a community to some of the work to create separate ICD-10 CM codes for some of these concepts. So welcome to the call. We're really happy to have you here. Next slide. Thanks for joining. Due to the usually large number of attendees, all participants are muted upon entry. We ask that you remain muted to avoid background noise. We always record our calls. Recordings are always available on the Gravity Confluence page after the meeting. You are encouraged to actively participate in the discussion using the WebEx chat feature. Please send chats to everybody. We do make efforts to pause and integrate chats from the chat box into the conversation. We really try hard. If we somehow miss something, please let us know. But it's our intention to make sure that any chat going on is integrated into the conversation as a part of our public work. Next slide, please. This is our antitrust practices slide. Next slide, please. So just if you have not done so already, we invite you to officially join the project at the Gravity Join the Project Confluence link. As we go forward, I do want to thank our team for dropping in hyperlinks into the chat. You can follow those links to whatever kind of content we're referencing. I do want to state, just as a courtesy, usually with WebEx, you have to click it twice because there's an initial block, and then you go through and to the link, and it takes you where you need to go. So we invite you to officially join the project, and then if you want to check whether you've already signed up or your friends have signed up, you can check that there too. And then the Confluence just remains a really good place to find out all kinds of information. There's everything we're doing, everything we've ever done is all there. It's quite massive. Next slide, please. This is our kind of revamped list of project founders, grantors, and in-kind support. It's broken down across our different stakeholders. So we have providers, social service orgs, payers, technology vendors, and government agencies. Really, really grateful for all of our friends. You know, it's many hands make labor light, always in this work. Next slide, please. We still are looking for additional sponsors for 2020 operations. So we really we really lean on our sponsors for sustainability. We're not a 501c3, we're a public collective. So this is how we fund our work. If you're interested in learning more about sponsorship opportunities, please send an email to gravityproject@emiadvisors.net or visit the Confluence page again regarding sponsorship, and it has all the details there. Next slide, please. So first of all, we're going to go through announcements and then introductions, and then we'll go, there's a lot of Sarah talking, and then Greg Harris, our acting technical director, will give an update on the technology, and then we'll close the meeting. Next slide, please. announcements. Next slide. All right, so Evelyn, is Evelyn on the call, or Mark? I believe Evelyn is on the call.
I'm on the call. Yeah, sorry. Mark, I put him on the agenda, but he's on break today, so I can.
I'm here too, Evelyn, if you need me.
Yeah, I
Oh,
just
you are there. Okay. So maybe Mark, you can go through the last. I'll just do the first bullet and just remind everyone, if they hadn't seen our first announcement about going to him. So we do have 2 education sessions. I will be doing one with Deb Donovan, one of our co-chairs, executive committee co-chairs, and then Bob Dieterle, our senior advisor, will be presenting on the Fire IG. We also have an opportunity. We'll have an education session at the Salesforce booth. So please reach out to me actually directly if you want to connect. And with that, I will hand over to Mark to talk about policy updates.
Thanks. So as some of you may know, the deadline to submit comments to the White House on their request for information on strengthening community technology, community health, was extended to March 31st, but strategically we went ahead and submitted early, so last Friday, so that we would get some personal attention, and indeed that did happen. We got a response from the Office of Science and Technology Policy thanking us, and we're looking forward to reading it without having the deluge of other comments to distract them from the importance of Gravity's comments, which largely was to lay out the Gravity project as a successful national model in much significant part due to the work of this collaborative to try to provide a quality result. Encourage the office to incorporate Gravity standards across regulations, not just in some of the areas where we've been successful so far, like USCDI. To think about funding and training for community-based organizations on the ground that are trying to build out the workflows, bridging digital divides, and integrating bidirectional exchange so that we can also input social determinant of health data, not just sort of statically view and access it. So we'll see what the result is, but we did submit early and have already gotten attention, and that's great. And the last bullet there, we are drafting a comment letter to CMS. You may recall that CMS, for its Medicare Advantage special needs plans, which already must do health-related service assessments, they're thinking now of including a question for each of food insecurity, housing instability, and transportation access from the Gravity SDOH assessment data element that was in USCDI, that is in USCDI V2. So another great example of integrating into federal standards, and we're working on a letter back, and that'll be due next Monday. Thanks much. Back to you, either Evelyn or Sarah.
I think it's me. All right, thank you so much, Mark and Evelyn. Next slide, please. We're seeking nominations for our executive committee. Nominations are due on or before March 4th. Evelyn, I don't know if you want to speak to this anymore. They're due before 3 p.m. Eastern Standard Time. Send nominations via cover letter and resume to gravityproject@emiadvisors.net. Subject line, Gravity Executive Committee nomination. The Executive Committee is a really amazing opportunity to help guide Gravity's strategy and ground our work. We really would appreciate anybody from the community stepping up to that nomination. Evelyn, anything else to say there?
No, thank you. We have a call, and we also on the reference the operational guidelines if you want to learn more. But yeah, we look forward to submissions, and thank you to those that have already submitted.
Awesome. Okay, next slide, please. And then, so this is, if Gabby is on the call, or I can actually leave this to her. Gabby, do you want to speak to this?
Hi, everyone. It's Gabriella. You can call me Gabby as well, for short. We welcome participation. We are currently seeking entities that are interested in piloting our amazing work done on the standards in terms of the coded concepts, as well as the technical HL7 SDOH Fire IG. We'll be starting up pilots affinity group in the spring. It will be a once a month call and it will be separate from our community call. We'll make sure that there's no conflict. And in terms of what entities we're seeking interest from, if you are looking at the roles right now, those are highlighted there. And if you have questions, we are available to answer them. Thank you. And I'll give it back to Sarah.
All right. Okay, next slide, please. There will be more information on the Confluence regarding the pilot affinity group. We just want to say in general, we're so excited for all the interest that we hear about this group. It's kind of a next phase of our public collective, really the implementers. And so we really look forward to convening all of you and having conversations regarding all different kinds of piloting, whether it be terminology or exchanges or the complete ID. We're just super excited. Okay, next slide, please. All right, so this is our roadmap. We are officially kickstarting health insurance and medical cost burden. We've been addressing health literacy. We're still, you can see that terminology is on top, and then the ID work and technical work and the pilots work goes below. So the technical team, as they'll go into in their presentation, are working on ballot reconciliation and planning for the next Connectathon in May. And then, as we just heard, we are actively initiating our work in pilots, and I'm very, very grateful to have kind of all systems go in our work at the Gravity Project. So it's a good time. Next slide, please. Any questions on the announcement sections that we've presented so far? All right. Okay. Next slide, please. This is where terminology talks about terminology build and terminology identification over the course of the next few minutes. Next slide, please. Next slide. I'm going to pass the mic to my amazing colleague, Linda Hyde, who's our Senior Terminology Advisor at the Gravity Project. This is where we get to talk about not just what we want to build, but what's released in the ecosystem because of our work. Linda?
Thanks, Sarah. Yes, there are a few things to update here. I think we mentioned in the last meeting that Loink was due to release shortly, but they did a release mid-February that included several SDOH-related screeners, some submitted by Gravity and others submitted by their owners. The three that are out there now are Children's Health Watch, Housing Stability Vital Signs, the American Academy of Family Physicians Social Needs Screening Tool, and the Health Leads Recommended Screening Tool. So we will be working now on updating our master lists and our screeners with available code spreadsheets to add those codes for those screeners. We're currently working on submission and process for an elder abuse screener and an intimate partner violence screener. Those will be going in shortly, hopefully in time for an upcoming Loink release in the summer or next fall. SNOMED CT actually released on March 1st, earlier this week. And in this release, we have an initial group of transportation interventions, and we have a number of diagnoses across multiple domains listed here: transportation, social connection, stress, education, intimate partner violence, and elder abuse. Again, we're working now on updating our master lists with the new codes, and from there we will be updating VSAC for the appropriate value sets that will include these new codes. And ICD-10, it's been busy. This seems to be the busy time of year for terminology work, but the ICD-10 CM Coordination and Maintenance Committee meets next week. Gravity being Sarah, will be presenting requests that we submitted on next Wednesday, March 9th at approximately 11:25 Eastern time. And it's approximate because it's a series of presentations. Some may be shorter than others, are longer, but it will be somewhere in that time frame for anybody who might want to listen in just for the Gravity section. Our submission includes requests for material hardship, social connection, elder abuse, intimate partner violence, and history of military service. I haven't looked yet. I was going to look just before the meeting, but I haven't looked. But as of yesterday, the final agenda was not posted, but we will provide the meeting information as soon as it is available for those who may want to listen to the presentation. We'll put it on Confluence and likely send some kind of a communication out. And that agenda will have all the details of all the submissions for the diagnoses, as well as the links for how you can join the meeting. And it's a free and it's a call-in. Anybody, you don't have to pre-register. You can just use that link that's in the PDF that's sent out to get on to the call. I believe that is my section.
Yeah, I'm going to answer some questions I see in the chat. And then I also want to mention one other thing from the previous slide. So the ICD submission is to the ICD-10 Coordination and Maintenance Committee, which is a division of NCHS, which is a division of the CDC. So so it's to the NCHS ICD-10 Coordination and Maintenance Committee. That's a lot. That's yes.
Sarah, for the history of military services, do you have everything?
Yes. So Dr. Rose wrote a wonderful letter. So yes, thank you so much, Charles. I want to give credit to our friends at FIRM and the VA and the DoD for really ensuring that we were able to resubmit that and elevate that and kind of comment back on the original solution the committee had presented in September to really ask for that separate code. So Charles, we owe great thanks to you for coordinating that response, and we're very grateful. I think we're all set.
Do you mind send me a copy offline?
Oh, no, I don't mind at all. Do you want me to? I'll forward the email Dr. Rose sent to me.
Please, thank you.
Absolutely. Okay, so that's one. And then there will be a link to the ICD-10 meeting once the final agenda is posted, and we will communicate it probably, well, ASAP as soon as we can to the community. And that's the answer to Tom's question. And if we can step back one slide, just to the previous slide. I want to settle for a second on the what it means to have the Children's Health Watch Housing Stability Vital Sign in the ecosystem. Well, really, all three of these are really like best in class and use as much as possible fully psychometrically tested tools. But the Housing Stability Vital Sign was the source of many of three of the diagnostic codes that we put into SNOMED CT. So it's a really direct link. Like you can use one of the questions and create an outcome, another question and create an outcome, another question and create an outcome. So it's very logical how the three questions and the Housing Stability Vital Sign lead to problem statements in a patient encounter. We really do hope to get clear education about that out into the community, but just know some of the tools that we've used are so evidence-based, they really are directly aligned with the diagnostic terminology we're proposing, and the Housing Stability Vital Sign is one of those. The Health Leads screening tool is like a screening tool of screening tools. So there's a lot of real estate in there. I want to remind folks that that one tool is very clearly aligned with literacy levels. So if you go into Health Leads tool and you have literacy guidelines within your implementation, Health Leads guides you into literacy levels of the different tools that are in its set. I just wanted to make sure that we reminded everybody of the opportunities that are in those tools, and some of our look for education coming forward regarding specifically how to implement terminology in line with these screeners. We hope to get that out into the ecosystem as soon as we can. All right, next slide. Thank you, Linda. Any other questions on ICD-10 Coordination and Maintenance Committee presentation? It really is the application of the robustness of our analysis of the domains we've covered so far, filling in gaps of critical terminology for diagnosis.
Sarah, I guess I would ask, what is the gap or the lag time between your presentation and the presentation of others on March 9 and actual incorporation of new codes?
That is very difficult to answer because it's the process with the ICD-10 Coordination and Maintenance Committee is not necessarily linear. So this is actually, some of these things are revisions of things that we presented in September that that had to be resubmitted, right? So there is no guaranteed it gets submitted, it gets approved, and it comes into the ecosystem, but usually it's about an 18-month lag time if things are approved and then released. And Linda, did I say that correctly? I think I did.
Yes, Yes, it would be not this fiscal year, but the following fiscal year, October.
But again, that's just as if
Yeah, that's if everything goes well from this meeting, there's no comments or concerns or revisions. That's the earliest it could possibly go in, but that's not a guarantee.
Thank you.
And Rita, hi Rita. Rita's asked a question about whether terminology is also going to be tied to intervention codes. There's a lot of actually implementation happening with that already in the ecosystem because of the availability of the value sets in VSAC. This is actually really in the realm of implementation. So for any diagnosis, you could have an intervention bundle that would be directly aligned with the intervention codes within VSAC. And that's 100% able to be done, right? And we do know with our when it aligns to quality measures, for example, if there is an intervention concept or intervention activity within a quality measure, and with the partners that we're working on with quality measures, those interventions aligning with the domain diagnosis will be part of how that measure is met. So it's kind of up to implementation, but absolutely the idea would be that you could have an intervention like pack based on the value sets in VSAC that would align with the diagnosis. With the understanding, as we talk about all the time in Gravity, that we are a Venn diagram of needs, right? So not everything that might be appropriate for an individual might be found in that value set, the intervention value set, but it will be as aligned as possible. Did I answer your question, Rita? Okay, good. Okay, next slide, please. All right, again, so this actually goes back to the Pilot Affinity work group. So part of our convening, when we start convening a specific subdivision of that group, is really what we've always called a kind of phase 1 testing, which is testing the terminology. The terminology we created, much of it's been available for some time now in the ecosystem, and we know individuals are downloading this terminology, downloading the value sets and implementing the terminology in care of patients in real time right now. So we have really like a lovely little group so far of implementers to assist us with evaluating the hypotheses we've made and built. But if you want to be part of that work, please just send an email to gravityproject@emiadvisors.net, and we'd really love to have you involved. We have some questions specifically really around our intervention approaches and our goals approaches. We would love to see how they're playing out in real time. Next slide, please. Come play with me. This is Sarah. This is hanging out with Sarah and the terminology team and just asking questions and figuring things out. So now we're going to go into our 3 domains we're talking about today. Next slide, please. So you can see this is the terminology schedule and activities. I do want to highlight some changes that have been made to some of the domain names based on how things evolve. This happens often, but it doesn't actually change the content of what we cover. It just it aligns the name with best practice. Charles, yes, hi. Do you have a question? Or no? Oh, I saw a hand up. Okay.
No, thank you. That was from the old.
Okay. Okay. So we kicked off health literacy in early February. I want to note a change here. So we were really grounding it in personal health literacy, but we've backed off a little bit because sometimes some of the MEPS activities that are aligned with Healthy People 2030 really are in line with organizational literacy, and we just have decisions to make as a group. Whether we include those elements, which really are assessing the ability of the team to assist the patient, as opposed to assessing the patient's own health literacy. We have to decide whether we want to cover them, how we would cover them, because there are some technical and implementation issues. So for that reason, we've kind of, for now, calling it more health literacy in general. So numeracy is included in health literacy as part of a subdomain. Yes. Hi, Carrie. We don't know, again, whether, you'll see this in our questions, we don't know whether we have a use case for identifying every single specific subtype of health literacy. We have to decide that as a group, or whether numeracy will be understood as part of the concepts of health literacy, and we will go forward from there. So we are now kicking off medical cost burden and health insurance status. and you'll see our slides regarding that today. Your homework, as always, is to try to submit concepts. So we haven't had a lot of submissions. We really, really want to make sure that the screening questions and answers you're using in your ecosystems are included in our work, that the programs and professions of people who help connect your patients and clients with services are included. So please, please, if you can, download the submission spreadsheet and get your terms and your tools to us so we can include them. Lucy, that's a really good question. We actually raise an issue regarding the primary English as a primary language and complexities of that later on in our slides. And so I'm going to hold that just because there's a whole slide that talks about that. So of course, as usual, you're clairvoyant in that matter. Any question on the schedule and activities? Again, if I can just plead one more time, submit your screening tools to us, submit your programs to us, get us the data that you need, because we're only able to represent the activities you're doing if we know what they are. Otherwise, our work is entirely based on literature searches and just making sure the team goes out there and just tries to glean everything it can. But we really want to make sure it's robust and complete. Next slide, please. Cinderlyn, no, it does not have to be in LOINC format. And you'll see that the submission sheet looks like a LOINC format because we have to then submit into LOINC. But we do not, you do not have to submit it in LOINC format. You can even just send us the screener, right? We'll do the best we can. We try to really meet people where they are, but it doesn't have to be in LOINC format at all. And then would the FQHC sliding fee scale be a program? That is one of the, yeah, that would be, well, Carrie, I'm not going to presuppose anything. So submit it. Go ahead and submit it, please, because that sounds like that is the best way to get things into the ecosystem. So thanks. Next slide, please. Okay, next this is our grounding slide. This is just stating what we know, that social determinants of health offer positive and negative forces. Next slide, please. Health insurance status. Next slide. And I'm sorry, it says, so this is we're going to go to some kickoff elements, and then we'll go into health literacy updates later. So health insurance status is actually really directly akin to some of the work we've done in the past, which is really a statement of fact. We've had things like this with education status or veteran status. It's a really very, very critical policy initiative, no longer on our announcement slide, but very much a CMS initiative is trying to increase the percent of children, families and pregnant individuals, who, decrease the number of children, families and pregnant individuals who are uninsured. So all of the questions that we ground our work in are all based on federal approaches, whether it's the National Health Interview Survey or the American Community Survey. This is just an example of the NHIS survey. So it's a two-part question. Are you covered by any kind of health insurance or some other kind of healthcare plan? Yes, no, refused, or don't know. And then what kinds of health insurance or healthcare coverage do you have? And it just gives the breadth of different options. This is just, again, one of the many different questions. There are individual questions you'll find on different tools as well. But in our work, we definitely try to ground ourselves in the federal approaches. Thank you. So this is just an example set. So Lucy, the comprehensive set of health insurance types is quite robust, but if you want to submit a concept regarding a health insurance type, that would be helpful. The one thing is this is an example of the screening question and answer. So we can't amend the screener, but we do want to make sure we represent the type of insurance in our programs if possible. Next slide, please. Are we going to consider insurance instability? So insurance instability is partly represented in some of the questions and answers we have within our screening approaches. Yes, the precarity of having employer-aligned insurance. Yeah, so it depends on the questions and answers you're asking, but some of those concepts are covered in some of our screeners. Just as a health insurance status, why? So 8.8% of the total population has no health insurance coverage according to the last American Community Survey. 5.1% of children have no health insurance coverage. In many different studies, Medicaid's a proxy for income status and children's health outcomes. If you look to the literature of Children's Health Watch, this is very much the case. We do know that literature shows increased mortality among the uninsured, and according to vast amounts of research, and you'll see it on the next slides, it affects access to care and preventive services. Next slide, please. This is just a few tables from the Kaiser Family Foundation regarding how insurance status and barriers to care, both among non-elderly adults and children. It's from 2017 data, but it was published in 2019. You can see presence of insurance, it influences not having a usual source of care, postponing care, going without care due to cost, and going without prescriptions, and having extended contact between primary care based on uninsured status. There's also, just of note, dental is included in some of the questionnaires. So health insurance is inclusive of dental insurance in some of the questionnaires and not others. Next slide, please. So just policy, again, the Healthy People 2030 goal is increasing the percent of the insured. The CMS goal is to increase the coverage of children, parents, and pregnant people as identified by the announcements on the 2 previous meetings, but not this one. There's a Healthy People 2030 goal of reducing the proportion of adults with disabilities who delay preventative care because of cost. You'll see there's a really clear intersection here between health insurance status and medical cost burden. We're going to be stating very clearly that medical cost burden is the presence of the debt. So we look into health insurance status as one variable in one domain, and then the burden of financial out-of-pocket costs that the person is carrying as the medical cost burden domain. So these are obviously related, but separate concepts. Next slide, please. All right, any questions regarding health insurance status?
Sarah, I guess I have to ask, compared to a lot of domains that we've dealt with since the beginning, at least my impression is that there was a terrible gap which we filled with our community discussion about various domains. Is that the case with health insurance? Isn't health insurance, like, you can't go to the doctor, a private physician, without stating your health insurance. So, and without presenting evidence of it, at least in a lot of settings. You just can't get in the door. So I guess I'm wondering about
The use case.
what is the value added here for us to be discussing presence or absence of health insurance?
I'll try to run through a quick use case, for example. So it's true that in many instances, you have to document the presence or absence of health insurance, right? You can pay cash. You also can go to clinics that do, like sliding fee scale or subsidized care that don't necessarily require all that documentation. But what is missing right now from the terminology ecosystem is the presence of the risk of not having it. Right. So if you're doing, like, for instance, there's no current problem statement regarding not having insurance, right? I can say, so if I was trying to do direct care coordination or risk stratification regarding uninsured in my populations, and I was using problem statements or SNOMED codes or diagnostic codes to drive all of the other elements, such as food insecurity or transportation insecurity, I wouldn't be able to do that with the uninsured in my population. So having so that's one thing. And then there's also not all of the program interventions. So we might be able to have a standardized and required way for asking whether the insurance exists, but do we have standards for the diagnostic statements, the goals for care planning, and the interventions we do in clinical settings to kind of amend that gap? No, we don't, right? So maybe one part, it's the same thing actually with education. It's a core element to document a patient's education level. So as with so that would have been included for less than a high school education, but actually addressing the risk, documenting the risk, all of that data is missing in the ecosystem.
Thank you. Of course, I was not implying that you can't get health care if you don't pay. I was just looking in the chat. So thank you for explaining that.
But did my answer about?
Yes.
Okay, great.
Yeah, thank you.
Wonderful. All right. And again, in many instances, the heft of our work is really documenting the interventions and labor involved to address the need, right? That is a huge part of what we do, is documenting the programs and people that are critical for addressing the needs that we identify in our clinical settings. All right, next slide, please. Any other questions, actually?
I had a quick question, just to be clear. We're saying that the source of payment typology and administrative terminologies or null values wouldn't work to indicate no insurance or anything like that?
We're not saying that they wouldn't work. We're just, I think that's actually work that we have to figure out together, whether we want a specific terminology for the statement of the absence of the thing, right? What we're saying is that the use case driving our work is that even if you were to state a null value of the absence of insurance, it'd be difficult to wrap around interventions around that, for example. Like how are you connecting a patient to services or referring them to social work for X, or that's all driven by diagnostic terminology that we have to figure out whether we need or not, right? And all the programs to intervene on the thing, they certainly are not there right now in the ecosystem. Am I understanding your question correctly?
Yes, I'm just thinking about all the places this could be. I do a lot of work with some government agencies.
Yeah.
Trying to get this information, insurance status. And I totally agree that, an administrative terminology has its drawbacks. But it's also hard to get what has been demographic data in a clinical terminology in a way that kind of works for both. So you're not asking people to do the same thing twice. You know what I mean?
Yeah.
And I'm just kind of wondering if there's a way we could have it work together. I don't know the answer. I'm just,
No, but that actually reminds me of some of the work we're doing across, personal characteristics and demographic data across our work in the IG as well. I think that's actually something really important to raise, and I think that kind of question is really important when we consider how this integrates with the fire IG work. In my mind, that's an important factor to bring to the technical team. So thank you for raising that.
Yeah, it's something we're struggling with too. So thank you. I think we're all struggling with it right now. So thank you so much.
I know. Yeah, so Brian's asking, does health insurance and stability include dental care insurance? Yes, it does. And depending on the screener directly queries for it. Some screeners do not and some do. All right. And Jonathan is raising the critical role of EMT in addressing the needs of individuals, and thank you for that.
Well, sorry, and thank you so much, Sarah. You're awesome. But it's actually specifically EMTALA. I don't know I don't know if everyone's familiar with it. Long story short, I once described it in an article as the most powerful healthcare law you've never heard of in this country. And it is the law behind the sign when you get into the hospital that says even if you can't pay for it, care will be provided to you. That is absolutely relevant in an ambulance, because if you don't talk to someone in the ambulance, you still get care. If you can't talk to someone, you still get care. So one thing that often comes up in discussions of social determinants and EMS, mobile medicine, is that many people know this, right? So the people who utilize ambulances as their primary care setting, many of them, like a quarter of them, so a lot, essentially don't pay for it. There's a multi-billion-dollar hole that goes absorbed by the industry because of that every year. Folks refuse to talk to the provider, give their name, give a social, or they are unconscious and they don't have any information later. They refuse to give it once they wake up. So to the degree that, unfortunately, there is a downward skew from an economic perspective as to who uses ambulances, and there is a correlation there among folks who may not pay for that service.
Thank you,
And so
Jonathan.
Yep.
Yeah, we don't ever want to forget the critical role of EMT in addressing. So thank you so much for raising that here. And I think there's, again, this is partly why we have our broad collective with many different stakeholders, just to understand all the variables. Art raises something pretty interesting here, which is true. Precarious health insurance does not capture administrative data related to a healthcare encounter and requires more detail. I do want to state, though, precarity of health insurance. In our surveys of standardized screening methodology, it's difficult to find good question and answer sets that represent that. We think about things like correlates to like the housing instability screener, right, which offers like a 12-month look back, like have you lost or have you worry of losing, right? So one of the things that we really depend on our community for is making sure that those concepts representing precarity are included in our build, and in order to be included, we just need you to submit them. So if there is a standardized screening and question answer set that you're using in your setting that addresses precarity, please submit it so that we can include it in the set. Any other questions regarding health insurance status? Okay, lovely. Now,
Would precarious also be a look forward?
it could be a look forward to. Yeah, you think about like I at least.
I think I'm going to lose my job in 3 months because the company is moving out of the United States, and
Yeah.
so I'm going to lose my health insurance. That use case.
Yeah, so yeah, and if
Okay.
there are standard questions that encompass that, either looking forward or looking back, for exactly, Carrie, right? Or even abusive work setting, right? So I was just talking to a patient earlier today who will not have health insurance in 2 weeks because they left an abusive work environment and are going to a work environment that doesn't offer insurance and benefits. So,
Okay. Thank you.
Wonderful. Again, we need those questions and answers, though, to have them included in our work. And we do try. We spend many, many countless hours searching and searching and searching, but we need our community to help us find those terms.
That's why we're asking questions, to test how much you've already done.
Lucy, I hope
Thank
that's
you.
not why.
Thank you.
Oh my Lord, I didn't know it was a test. All right, on to medical
I'm
costs.
just teasing.
I know.
Okay,
I know.
All right,
You're very
bye.
sweet. All right. And again, so Carrie's raising up people not leaving a domestic violence situation. And I just want to state, of course, there's intersections. We remember this being a super, super critical element within housing instability and homelessness. So any kind of situation, these all are intersecting in the lives of the individuals we take care of on a daily basis. So now onto medical cost burden, which is a different half of the coin. Next slide, please. So medical cost burden is really a measure of financial pressure resulting from health spending stemming from inadequate resources to meet medical cost needs, right? So an example of this is from the paper Caraballo et al. So in the past 12 months, did anyone in your family have problems paying or were unable to pay any medical bills, including bills for doctors, dentists, hospitals, therapists, medication, equipment, nursing home, or home care? Do anyone in your family currently, oh, sorry, I should say currently, not currency, currently have medical bills that are being paid off over time? This would include medical bills being paid off with a credit card, through personal loans, or bill paying arrangements with hospitals or other providers. The bills can be from earlier years as well as this year. Or do you or does anyone in your family currently have any medical bills you aren't able to pay at all? And I want to kind of give a use case for this, right? So I can be underinsured, right? I can have an incredibly high deductible. I can have the lowest of the low plans that the state offers or my employer offers, right? And I can get sick, not at all, and I can have no out-of-pocket debt, and that lack of insurance is not borne out in my daily experience. It's a risk, but it's not imparting a daily experience in my daily life. If I have that same bronze plan, or if off the state insurance I got the lowest plan and I have a really high deductible and I get hospitalized with pancreatic cancer, right? Or my child falls and breaks a leg, right? You start amounting debt, right? So the health insurance status works as an evil sister to medical cost burden, because in a situation where you are either uninsured or underinsured, and you actually have medical spend that's out of pocket, it becomes something that's directly concerning and associated with all kinds of concerns in the literature and health outcomes. Does that make sense? Just as a reckoning of why these two things are grouped together and why medical cost burden is distinct from underinsurance? It sounds like it's so. The story was so telling. All right. Next slide, please. So medical cost burden, why? So we know from the literature that medical cost burden leads to broad financial burden. It leads to, there's a really lovely graphic that I didn't get rights to use, but it talks about the intersection in medical cost burden, lost work time, under education, and just decreasing financial hardship over time. Medical cost burdens associated with food insecurity and other hardships as individuals make choices, like, do I pay off my ER visit, or do I pay for food? I'm sorry, I'm getting really emotional right here because I have a underinsured patient who is currently abstaining from getting her coronary, her cardiac cath, because she literally can't afford it. Right, so we know she has severe coronary artery disease, and she can't afford the cath because her insurance is not robust enough to afford that. So medical cost burden leads to lack of access of care as you make choices, like, I'm not going to go to the doctors or to see my provider. I'm not going to get that colonoscopy. I'm not going to not going to get my mammogram this year. And inability to follow treatment plans. Like, I might recommend, like, for instance, that my patient see cardiology and get care for her coronary artery disease, but she is unable to do so. And then it also has outcomes with decreased trust in provider treatment plans. So as there becomes dissonance with the recommended plan and what the patient is unable to afford, there's decreased trust and a breakdown in trust because there's not a lack of understanding of the burden of the patient and how it's implicating their choices. I would love to send the reference to the graph, and if it's published, and I'll drop that. I'll put that on the Confluence. We do try in our Confluence to have references, and I will put it there. So these are all the literature whys about why medical cost burden is important, and some of the citations and papers will go up on the Confluence. Financial pressure, yes, we need financial obligation. So we can, I pulled it directly from the lit, so I couldn't change it, but I understand why pressure would be misinterpreted. And then, oh, Ned, of course, I also got a little verklempt. And then Carrie, you have a question? Help me. Hi, Carrie. Yes? Do you have a...
Yeah, I do. Does this domain include...
Oh, I can't hear you. I see your hand. I heard you first, and then I can't hear you anymore. Maybe, Carrie, it sounds like we're having some problems. You know that I respond to any email you send me, even if it's a couple days late. So Carrie, Carrie, I have to give a shout out to Carrie, an incredibly invested member of our Gravity community, and I'm so grateful for her. So just if you send me an email, I'll try to answer you on an email and then bring it back to the group next time. We do. All right. Any other questions regarding the medical cost burden? Why? Okay, so next slide, please. There, I want to bring to light, you're going to see how this is kind of similar. You saw this on the health insurance status policy slide, but the reason why this is kind of on both is because if the person already has medical debt and they're delaying getting further debt, it falls into medical cost burden, right? If the person is simply not getting anything and they have no debt, it is health insurance status concerns. Well, that is an argument that can be made. So Char is saying, I would argue that anyone who has a high deductible plan has a medical cost burden, except for the fact that by definition is actually the presence of the debt to the system and the out-of-pocket expense. So for instance, my if I choose my employer's bronze plan, I actually pay less in money upfront, but I pay more if I get sick. But if you have a greater if you have an argument to be made there, go ahead and submit it in an email and we can try to figure it out. And that's true. So also high income folk may choose higher deductibles and be ready with savings to address that. But the high deductible covers the catastrophic hospital illness. And so they're able to get there. They're able to pay the 0 to 10,000 easily, but they want to cover the 10,000 plus that would result from being hospitalized or getting a severe illness. That's true. Next slide, please. Here I thought we would have a short meeting and it's already 4:51 and we're going to go for the whole hour and a half today. I'm so sorry. Greg, we're coming for you, I promise. Next slide, please.
No rush.
Okay, yeah. Okay, Carrie, I will try. Does this include a cause of unexpected debt? For example, you can afford your insurance deductible, but the hospital you go to contract with a doctor who's not in your network. Yeah, so if that becomes burdensome, absolutely. Those surprise costs, absolutely, right? Yeah, so anything, it doesn't matter whether it's expected debt or unexpected debt, it's the presence of the debt that's burdensome to repay. All right. I'm going to go into health literacy concepts now. So some updates. Next slide. So we really are trying to figure out, again, what needs to be said. So we started out with a definition of personal health literacy. There's also a definition in the ecosystem for functional health literacy. They're very interconnected. So these are the two definitions we're kind of playing with right now, and we have to figure out how we address it. And this is part of what we're working on as a team. So personal health literacy is defined as, if you remember, that was Healthy People 2030. It's defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. This was stated that way on the page to differentiate from organizational health literacy. Functional health literacy is the more classic term in the lit. It's an individual's capacity to obtain, process, and understand basic health information and services sufficiently to make appropriate health decisions. So nothing to be said here right now. This is just kind of the stuff that we put in the hopper as we try to figure out what needs to be said. And we have decisions to make regarding what was really helpful for creating clear understanding in the ecosystem. And the second one comes from the IOM. Next slide, please. And then organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. This is where I made a little bit of an oops last time because I was talking about this as being somewhat different, but all of the MEPS questions, the medical expenditures questions and the alignment with Healthy People 2030, most of them focus on this, like how well did your provider help you blank? We recognize those concepts also from some of our, our primary care quality patient satisfaction surveys. So these are all elements of organizational health literacy, not what the person needs to do, but what we need to do for the person. There's some huge questions about this that we'll address in a future slide. Next slide, please. You can tell I'm trying to go quickly. We do have questions about some types of literacy that we need to figure out whether we build them. So we talked about digital health literacy and numeracy. So one of the things we're asking ourselves, and you heard me say this last time, is we might be able to find a use case specifically for digital literacy, how it relates to health literacy, but we're trying to figure out whether we have a specific use case for building a digital health literacy term. Same thing with numeracy, right? So we have to figure out whether there's a use case for specifically having a numeracy term or numeracy as a subtype of health literacy. There are some screeners that only ask about numeracy. So just like I was talking about with housing instability, if there were concerns about implementation, you could literally say this screener leads to this diagnosis. And it would be a little bit easier to implement because many of these concepts are a little bit remote to the clinicians in the field. We just have to figure out whether that's what we want to do. Yes, digital health literacy encompasses any skill required to access any kind of resource regarding your health. Absolutely, which is ever so critical in the post-2020 COVID pandemic period that was never ending, says family medicine. Sorry. We thought it would come and go, and it's here to stay. Next slide, please. All right, so this is just, again, health literacy domains applied. For the sake of time, I've addressed this last time. I'm going to move through it. Next slide, please. I really want to get to some of this is some tools that we already have in our master. I do want to state for those of you who love this kind of stuff, there is the master list for health literacy is available on the Confluence. So you can see the things that it's kind of the sandbox of what we work on and what's already been put on the list for screeners, the terms we're thinking about for diagnoses, and you'll see those shortly as well. But that master is available on the Confluence for anyone to see, find, download, comment on, submit, look at absent, like missing screener questions and answers. So that's the best way to start working with our deliverables. Next slide, please. All right, so I just wanted to go with the working diagnoses codes. You'll see it's divided with SNOMED CT and ICD-10 CM, ICD-10 CM and ICD-11. Anything in bold is an existing term. So if you look in SNOMED CT, there's unable to demonstrate health literacy and difficulty demonstrating health literacy. There were a lot of other terms. These are the ones that are most clearly aligned with our objective. So we've already made some choices. In ICD-10, there are some vague other problems related to education and literacy codes. But we do want to note that in ICD-11, already in the ecosystem, because it's already being utilized, there is a problem with health literacy code, right? So in ICD, we could imagine, you can see then on the ICD-10 side, we can imagine asking for a problem with health literacy code for ICD-10, which is directly aligned with ICD-11, and we'd be able to utilize it in the US ecosystem in advance of us taking up ICD-11, which would be fairly easy. So what is SNOMED? So SNOMED CT is one of the largest terminologies in HIT. It covers everything from screening questions and answers to like diagnostic problems, to social history, to interventions and procedures. I'm not allowed to have favorite children, but it's really quite beautiful. So SNOMED CT is one of the terminologies we build within, and it's everywhere in the US health records. Health literacy screening tools don't necessarily ask about broadband access internet use, but Rita, we are talking about that as part of our community domains in the future. Whoa, Karen.
I think, Sarah, wouldn't it be true to say that someone could be digitally literate but lack broadband, which is an organizational, actually the concept of organizational literacy ought to include broadband.
Well, that is a different concept though. That's digital equity. That's not, so it's not a clinic's, I mean, by definition, they are aligned, but they're not the same. Just like a lack of having a phone is different than being able to use it. Or lack of having a computer is different than being able to use one if you had one. The Center for Digital Equity did do a really good job explaining this. But we did address lack of having the equipment in our material hardship domain, and we are addressing the lack of the thing in the ecosystem in our neighborhood and community domains in the future. We covered internet, we covered this person doesn't have this thing somewhat within material hardship, but we do have more work to do there within the broadband element. Charles just said, Sarah.
Sorry.
What is that?
Sarah, sorry.
Okay, anything else? Okay, and Carrie, I'm going to pause on answering that question because I have a statement that might be related to it. I don't know if it is though, Carrie, but you can see, so under SNOMED CT, these are some of the concepts we're talking about, whether or not they'll be necessary. And Charles, did you have something to say? I'm so sorry.
I do. I am sorry too. I had an echo and couldn't speak. We are involved with IEEE with medical devices, how to utilize medical devices for seniors or patients who have problem interacting with medical device, digitally speaking. So I don't know if that's relevant, and if it's so, happy to bring some information into that. So, but definitely we are involved in improving the standards of utilizing medical devices
Yeah.
for under the literacy umbrella.
Great. I do want to caution that we uncovered a need to consider digital literacy by working on health literacy, right? But it's not necessarily on our domain and on our plan right now, right? We had health literacy, medical cost burden, and insurance status, right? So this is what Gravity does, is it when it realizes critical linkages, we have to figure out whether we do this now or whether we do it later. But this is partly why it's here. Thank you, Janice. And then,
You're welcome.
all right, and working on, so ideology and vaccine hesitancy is very relevant, and we're going to, I have a statement on that in a couple of slides. So everyone understands that this is the hopper for the sandbox for diagnoses codes across SNOMED, CT, and ICD-10, and ICD-11 as it stands right now, just the things we're thinking about. Okay, next slide. And you'll see this on the master. And then we do always have a goal statement, able to demonstrate health literacy as a finding statement. And then this is currently on the master as well. Next slide, please. I believe we are pulling in some of our intervention concepts from other bills. You can see from education, there's a lot in there. And because of some of the elements of social connection and health literacy, some of our social connection and peer support programs are appropriate in this domain as well. And of course, library educational services, huge library fan. So all of these are pulled over from past domains and past build, and you'll find them on our master. Next slide, please. All right, so this is actually something that we're just kind of making as a statement, and there can be a little pushback on it. But we really have to be guided by standardized questions and definitions. And so right now, we had a lot of conversation last time about health literacy and the intersection of misinformation and health literacy. And there really is no standardized question at this time to kind of guide us in that work. So for right now, I mean, even though the use case for the intersection of ideology and misinformation and uptick of critical interventions is so 100% clear, says Sarah DeSilvi in rural Vermont, whose family practice every most days. We really are finding it out of scope to address that right now, right? If someone has a standardized approach and screening question demonstrates to us how we can imagine them as conjoined, great. If not, they are likely separate domains, and we really have to focus on what's purely within scope of health literacy right now, which is specifically the concepts that we've addressed in our current screening approaches. Does that make sense? Just because just from boiling the ocean, we really did try to figure out if there was anything out there that addressed the combination, and we could not find it.
This is Janice. I added that in the
Yeah.
chat. Yeah, because I've been to multiple conferences, and you can go from one workshop to another workshop. And if you've ever written a paper and trying to incorporate health literacy, you'll see there's so much differing information. We spent meetings just on that one definition in one of the equity papers I wrote.
Oh my gosh, yeah.
Yeah.
So I think it's okay to imagine this as a work in progress, like we're making initial approaches with our initial guardrails, and then over time, the iterative work, we might come back and loop around, and I'm sure we are all learning a lot about the intersection of misinformation and ideology in interventions at this time, sadly. Okay, next slide. So Sue Bowman that's actually a really important thing to agree that misinformation is different, but notice the definition of functional health literacy mentioned the ability to make appropriate health decisions. What's appropriate can be subjective and get into the misinformation issue. Yes. So again, Sue, if there's anything, yes, 100%. So that statement aligns right now. I think actually maybe a really important thing for us all to do is to go and look at the screening questions and answers that are currently in there. And if there is a way to find a question and answer set that ties that like misinformation and health literacy together, we would love to include it, but we just haven't been able to find it so far. Absolutely influenced by, 100%. Correct. Says, I'm just saying, Carrie, correct. And so this is, I want to bring back something that I mentioned to Lucy. So one of the things we're encountering that's a really big problem is how do we account for screeners that do not account for those who are not fluent in English? Sorry, I said fluent twice. You can, as much as I thought I spell checked these, apparently I did not. Because this is inherent bias, right? There's a lot of literature regarding the intersection of health literacy and English as a second language. We are really, really hoping to find as many screeners as we can in languages other than English. But currently, most of the screeners that we have are English-based, and that's a problem. In our approaches in other domains, if something was specifically biased against a certain gender, it wasn't included. We did a lot of this in intimate partner violence. If whole populations were excluded in the screening approach, it would be excluded from the set. So we have some work to do here just because of the paucity of non-English screening approaches within this work. So this is a huge, massive red flag that we need to figure out how to address. We also need to figure out whether we include measures for all subdomains of health literacy. We have to ask ourselves if we address digital health literacy independently, if it requires completely different interventions that might be necessary. And then we have to ask ourselves if we craft diagnoses for each different of the subdomains. And then we still have to figure out how we address organizational literacy assessments and interventions in our model, because we can ask the questions of the individual, but how do we intervene when the problem is the system and not the person? So Lucy, everything that we say is not in scope now is always in scope sometime, right? So, I mean, or I'm saying always, Evelyn didn't hear me say that. I'm saying it's up for consideration of being in scope at some point in time. Yes, yeah, I think that is what we do. But we have to just prioritize what happens next. And there's also, I just want to state in general, we have to figure out whether we go broad and address new domains, or we deepen the amount of data we're standardizing regarding our existing domains. We have a lot of choices to make. What does digital health literacy mean? Digital health is a concept sort of vague. There was a definition on earlier slides, which we can go back to. I just want, for the sake of time, I do want to, it might be best, Carlos, to download and look at the last meeting where we went into digital health literacy and the definition very clearly. Hi, Carlos.
Yeah, and Sarah, and that's fine. I think just when I hear the term digital health, it might mean kind of the industry of digital health with various kind of care management solutions. And
I know, and it makes sense why you'd be thinking of that. Yeah, so but digital health literacy is defined on an earlier slide. All right, next slide. Emma Jones, the amazing Emma Jones. She's an amazing member of the eCare Plan team and the Gravity friend. So grateful for you. I want to mention that we're convening again the Gravity Interventions Council. We have a few names for that group. These are all folks who can help us identify the programs, interventions that are critical for solving the problems we identify, or at least addressing them. It's very difficult to solve the problems without structural solutions, and we're talking about one-on-one with people. But I just want to state that if you have any interest in becoming part of the Interventions Council, please send an email to gravityproject@emyadvisors.net. Okay, I think I left enough time for Greg. Next slide. Whew. Any questions, friends? Wow. That was a good old rodeo as per usual. Thank you. Okay. Please submit anything you have in the ecosystem regarding any of the things we've talked about today, because that's how it becomes part of our work. I am now passing the mic to Greg, our amazing acting technical director.
I'm not sure how anybody follows Sarah after giving that delivery, but if you could give me the next slide, please. So what we've been doing over the last few weeks has been continuing to, I'm sorry, we're on this slide. Yes, so the Fire IG public meetings are scheduled on Wednesdays from 3 to 4 Eastern time. You can see the agenda and the calendars on the link in the presentation. And please go to the next slide. Okay, so we've been continuing to work on the remaining ballot comments. We're working through at the rate of approximately 10 every meeting that we have. You know, it does tend to be a fairly slow process. We've resolved 28 tickets from the last block vote. There are 8 tickets waiting for the next block vote, and 58 tickets remain to be addressed. So I'm guessing probably about another 6 sessions before we clear all these out. I will say that that's not a firm number because people can still submit further comments, but based on the number of them that we have at the moment, that should be about right. And that's it for me. Unless there's any questions.
Any questions for Greg? We do want to invite people to come to that Wednesday afternoon call. It's where a lot of the work of the reconciliation happens, and it's an amazing assemblage of folk. Any other questions for Greg? Look at that.
Thank you very much.
Thank you. Okay. Next slide. All right, community homework. If I haven't made it perfectly clear, what I really want you to do is submit concepts to us. I want you to find the screeners you use. I want you to think about the things you think we need to say. I want you to figure out the programs that you're using to address either health insurance concerns, medical cost burden concerns, or health literacy concerns in your settings, whether they be community settings, nonprofits, healthcare for the homeless, FQHCs, private clinics, hospitals, discharge care management, you name it. We want to know what you're doing and what you feel like we need to ask. So please submit those terms. And then you can always catch up on materials and recordings on the Gravity Project Materials Confluence. And then please, if you want to join that interventions work group, it is a really great time to just have, we basically meet once a month or sometimes twice a month to just go through how we can take care of people and what needs to be said. So please send an email to gravityproject@emiadvisors.net if that seems up your alley. Next slide, please. Thank you. Thanks for keeping me on my toes. Thanks for joining the call as always. Charles, you and I need to communicate regarding your question at the beginning of the meeting. I did not forget. And the Gravity team, as always, is ever so appreciative of your involvement. And thanks for being part of the family. And we'll see you in 2 weeks.
Thank you. Bye.
Thanks, everyone.
Thank you.
Thank you.
Thank you, Sarah, as usual. Thank you so much. Looking forward to Quick Connect.
Oh, always, Charles. It's always a pleasure. I'll talk to you soon.
Bye.